Hello, today we're going to be covering Advanced Medical Module 2. That's going to be going over pre-hospital diabetic emergencies. It's going to be covering allergies and anaphylaxis, and then lastly, seizure management. All right, let's go ahead and get into the case study. As pre-hospital providers, this is a good majority of the calls that we're going to run, right? I'd say, me personally, when I was full-time on the ambulance, I bet I ran an average of 5 of these calls a week. Some type of diabetic emergency, or even not, even going for other reasons, and then finding out that they are in some type of not necessarily diabetic emergency, but that we do need to take some corrective actions for their blood sugar. Pretty common, like I said, we run into this a lot. So I feel like this is something that we should be proficient in, and something that we need to be well-versed in knowing how to treat this, how to look at this, how to interpret this, how to diagnose this, if you will, in the field. So the more practice we get at this, the more we go over, the more we get to, read up and watch all these videos, the better off everybody's going to be, the better off our patient care is going to be, and the better clinicians we're going to be in the long run, right? So jumping right into this, pre-hospital diabetic emergencies. So some objectives we're going to cover today. We're going to describe the anatomy and physiology of the pancreas, the normal pancreas, and the associated symptoms of blood sugar regulation. How does the body do this? Okay, we're going to kind of dive into that, the what ifs, the what nots, all that good stuff. Number 2, we're going to discuss the pathophysiology of diabetes. So when it's not working right, what's it doing? What have we done to get ourselves to this point? We're going to get into all of that. We're going to describe the signs and symptoms of hypoglycemia and hyperglycemia. So both ends of the spectrum. We're going to talk about both sides of it, what it's going to look like, how it presents, and what we can do for it pre-hospital wise. And then finally, we're going to describe the pre-hospital treatment for the common diabetic emergencies, just like I said. We're going to cover both ends of it and but cover what we can do for these patients, okay? As medicine evolves, so do our treatments, right? So what my treatment might be, or my local protocol where I work, may be totally different from what you guys do where you're at. So just keep that in mind as we go through this, especially this first part of this case study here. So let's go ahead and get into the case study. All right. So I'm going to read this off from my paper here just so I don't miss anything. And I'm just going to put the key notes up here on this slideshow, as you can see. All right. So 6:45 in the morning, typical, we get off in 15 minutes, right? And you and your partner are trying to catch the last few minutes before the end of your shift. Dispatch alerts you and your crew to respond to a private residence where a 32-year-old male has been found unresponsive by his mother. Okay. While en route, the dispatcher updates you with information that the patient is unconscious, but it has a pulse and is breathing. All right. It is further reported that the patient is a known diabetic and that his family is present on scene to let you into the home. Man, I mean, talk about some golden dispatch notes, right? You don't hardly ever get this. You're going to get on scene and find the patient supine in bed, unconscious, pale, diaphoretic, and it's only going to be responsive to deep, painful stimuli, and he moans whenever you do like a real hard sternal rub. Does not exhibit any purposeful movements. Doesn't have any traumatic injuries that you can see from the first glance. And patient's family and his wife is on scene now. She's made it home from work. Mother is there as well, but wife is on scene. She's anxious and denies any recent drug or alcohol abuse. Okay. So you don't have no signs of trauma. Wife's on scene, says no, he hasn't been drinking, doesn't take any drugs. So that's not indicative of why we have altered mentation, right? So we're going to carry on. Get on scene, we see him, we're going to start making patient contact. We get a strong radial pulse at 110 beats a minute, right? His room air pulse ox is going to be at 94%. Initial blood pressure when we get on scene, 128/80, so not bad, right? We're doing okay. A little bit tachycardic, and that pulse ox is not really where we kind of really want it to be, right? I'm going to take a finger stick to get our blood glucose level, and that reveals 30, okay? So what are we doing next? Okay, so as an EMT or, as a BLS provider, our hands are kind of tied, right? We don't really have a lot of options. In this situation, we can fix it. He's not responsive though. So we can't give him oral glucose. We can't give him cake icing or juice or soda, whatever your trick of the trade is. We can't have him do any treatments like that because he's unconscious, right? So what are we going to do? What's our next step? All right. As ALS providers, as me as a paramedic, I've got different options here. And that's kind of what we're going to go into here, just so we'll kind of give you an idea of how it's typically going to be treated. All right. And, because odds are if we're on an ambulance now, it's going to be a EMT and a paramedic, right? I mean, few and far between you get, an advanced EMT and a basic and stuff like that. But we're going with our normal scenarios, and you've got a medic partner with you. And so kind of be familiar with those treatments. Okay. So we're going to get an 18 gauge IV, any large bore IV. We're going to try to get an IV, good, nice patent one. Make sure there's no redness or swelling at the IV site. All right. The reason for this being is D50 is extremely, extremely necrotic if it gets into the bloodstream. Okay. All that surrounding tissue, or not into the bloodstream. I'm sorry. Scratch that. But if it gets into that surrounding tissue, it is extremely necrotic. Okay. So we have to make sure it stays in the veins, it stays in the bloodstream, and it doesn't go anywhere else. Okay. So that's why we go ahead and push some saline through there, make sure that our line is flowing really good. There's no irritation. There's no red flags whatsoever. Okay. Because if we have some type of infiltration with that IV line and we push that D50, bad things are going to happen. Okay. We're going to push the 25 grams of 50% dextrose solution administered via IV push. This is where it's going to get different for some people. Okay. There's a lot of services now that are going to a 25% dextrose solution, a 10% dextrose solution. There's a lot of places that aren't really doing that strong 50%, because of what we're going to talk about later being that rebound hypoglycemia. Okay. It's enough to get them up and going, but it's not sustainable. Okay. So, you'll find some people that will say the argument is money based, right? That we're doing this D10 and D25 because now we can't push D50, have them wake up and we AMA them on scene. It takes us 10 to 20 minutes to get that D10 or D25 pushed in or infused in. And so we're usually at the hospital by the time they're waking up. Okay. I guess there's a point there, but it's better. Okay. We're gradually bringing their blood sugar up. Now there are still cases where D50 is going to be perfectly fine and called for. And this probably is one of them. He's unconscious. If he was conscious and just altered, started acting a little funny, okay, let's drip something, right? But if you're unconscious and I can't wake you up and I do I elbow drop sternal rub you and you just moan. Okay, so we'll push a little D50 and then we're going to go from there, right? So we give that D50, starts to come around. A few minutes later, if you guys have never seen that, it's like a miracle drug. Literally, it's thick syrup, sugar water. You push it in the IV vein or through the IV into the vein, and here they come. Okay, they wake up and they're like, oh my gosh. So a few minutes later, it becomes responsive, and we're going to recheck vital signs. Okay, got a pulse of 90 beats per minute. It's a lot better than 110. Respirations are at 16. All right, so they've slowed down a little bit. And they were high and they were elevated trying to compensate before, right? Pulse ox, since we did put them on some oxygen earlier, I forgot to mention that, but it's going to be at 100% now. And next blood pressure is 130/90. Blood glucose is 210. Okay, so we are a little high, but we are definitely functionable now. All right. So after that, we are going to tell the patient, typically what happens is, the patient wakes up, he's embarrassed. He's like, oh man, I can't believe, this happened. Wife states that the patient has been a insulin dependent diabetic since he was a teenager. He checks his blood sugar multiple times daily. Everything, he takes very good care of himself. Just so happens last night he had to work late. He's got a big work project. And so he had to work late, ended up missing dinner. But he took his Lantus before he went to sleep, and that's long-acting insulin. Okay, so that means it's time release, takes forever to process, all that good stuff. So he took that just routinely and didn't eat dinner, right? And so woke up with a blood sugar of 30. Okay, so He was embarrassed. He said, man, this hasn't happened 10, 15 years. I think I got it, though. I'm good. I don't need to go to the hospital. It's kind of a typical presentation that we see a lot. All right. One thing that I do want to note, okay, that's where we're at. That's what happens a lot of times. You've got to reiterate to these patients to go ahead and eat a very balanced meal, complex carbohydrates, and monitor that blood sugar, okay? Because you don't want that rebound hypoglycemia. You don't want that all that D50 that you just pushed, it metabolizes quickly, okay? Within like 10, 15 minutes. If we don't get something else to back up onto that or piggyback onto that, they're going to crash again. So we want to make sure, if you've got family members there, you say like, hey, how about you go make them a sandwich real quick, or whatever the case may be, but get some complex carbs in there. Make sure we get good, well balanced, get some protein, make sure that we're good. And it's a nice, healthy meal. Okay. That will let that blood sugar kind of level out. We maintain that homeostasis. We've got enough energy. We got enough, supplies to keep the train moving, if you will. Okay. All right. So enough on that case study. We're just going to jump into all of our facts now. All right. So we kind of just giving you the general idea of what this call is going to look like. Right. And that's the hypoglycemic. All right. Hyperglycemic. We'll talk about that later, and, Godspeed and good luck essentially. But, that was your hypoglycemia patient. That's kind of your typical call. Okay. So jumping into the introduction here. So diabetes mellitus is going to be a disease of the endocrine system where either the pancreas does not produce insulin or the body becomes resistant to the insulin that is produced. Okay. So either the body doesn't produce insulin, something's hereditarily wrong there, genetically wrong, and the body doesn't produce it at all, or the body does produce it and our health choices have just made it to where our body is resistant to the insulin that is produced. Okay. This disease is going to affect approximately 25.8 million people in the US. All right. It's about 8.3% of the population. 18.8 million people are diagnosed with diabetes yearly. And this is going to be 7.0. So 7 million, excuse me, are undiagnosed, living with some type of diabetic symptom. Okay. And we're kind of going to jump into these symptoms a little bit as we get into it, depending on which end of the spectrum you're on, as what kind of symptoms we're going to be looking at. But this is, we are looking at 7 million people that don't even know they have diabetes. That's crazy if you think about it. It's going to be the 7th leading cause of death in the United States, whether that be from, actual blood sugar variations or, HHNK or DKA or secondary issues that have been exacerbated by diabetes. Okay. And we're going to get into that. Like I said, CDC estimates the total cost of care for diabetes to be $174 billion annually. That's hard to grasp. $174 billion annually. Maybe, we could also think about maybe taking some of that 174 billion and kind of restructuring this into, the type of foods that we eat. I don't know, just a thought. All right. So anatomy and physiology of the pancreas. Okay. So the pancreas is going to be a small, solid organ that lies between the stomach and the duodenum in the anterior chamber of the retroperitoneal space. There's some Scrabble words for you there. So packed all in the middle, all in directly in the middle and between all that stuff that's jammed into your gut, right? Insulin and glucagon are going to be produced by specialized cells known as the islets of Langerhans. I love saying that. Within the pancreas. So it's specialized cells that are within the pancreas. It's inside the pancreas, only inside the pancreas, and they are going to produce insulin and glucagon. All right. Within these islets are 2 different types of cells, though. So you've got your alpha cells, and those are the cells that are going to produce the glucagon, and the beta cells are going to be the cells that secrete the insulin. Okay. So we've got to have both of those in a perfect relationship, right? Insulin. So insulin enables sugar, fatty acids, and the amino acids to be taken up and metabolized by cells. What this basically means is you eat food, okay? The food, the sugars, and all that good stuff in the food gets into your body. It's going to elevate your glucose levels, right? So the insulin releases, and it attaches onto these sugars and fatty acids and all the amino acids and all that good stuff, lets the cells metabolize them and use them. So they eat them up. They break them down, do whatever they've got to do to use all of that stuff as energy, right? That's going to be the primary source of energy at the cellular level. So without that, the cells don't have energy to live. Okay. So this is why this endocrine is it's so important, is because this is where the cellular energy comes from. Without insulin, they're minimally usable. All this stuff, you're eating all these amino acids, these fatty acids, the sugars, all that stuff, you're just intake. And if there's no type of insulin reaction, or if the insulin's not working, or if there's no insulin being produced, then the cell is not getting any use out of it whatsoever. And we're not getting power, right? We're not getting energy. So you can imagine the type of catastrophic event that's going to occur eventually if we continue on this train, right? Any food that's unmetabolized, so meaning that, it's not metabolized due to insulin doing its job and getting the cells to get that power. Any food that's not metabolized like that is converted to glycogen, okay, which is going to be stored in the liver for use later. All right. Fatty acids are converted to triglycerides and stored as fat. Amino acids are going to be metabolized into proteins and glucose, which equals energy, right? So when all this works together, the effect overall is a reduction in blood glucose level, right? So I kind of told you how this all plays together. Okay. We eat, levels rise, insulin's released, goes to all that stuff that we ate, lets the cells do their thing, get their energy, break it down, metabolize it, and then we move on with our lives, right? When we start to have stops or hurdles in that process, that's when we get into what we are talking about today, okay? So that was insulin. This is glucagon, okay? Glucagon, kind of familiar, right? We don't really carry insulin. Well, I take that back. I've carried insulin on an ambulance, but it wasn't for diabetes. It was for hyperkalemia. So potassium issues. But this is something that we see on our ambulance on our daily checkoffs a lot, right? Glucagon. That's the real expensive one. It usually comes like in a red box that, you better not lose this. It's really, really, really pricey, that one. It has an opposing function to insulin. So what this does is it stimulates the release of breakdown of glycogen into glucose. Okay, so let's go back real quick. Hold on, time out. So any food that is unmetabolized is converted to glycogen. Okay, so that's going to be, that glycogen, like we said, is going to be stored in the liver for use later. Glucagon stimulates the release and breakdown of glycogen into glucose. Okay, glucose is the actual product, the byproduct, what we use as energy, the cells. Okay, so if the insulin's not working, or if there is no insulin, then the body says, all right, fine, let's go to the glucagon then. The glucagon goes to the liver, goes to those cells and says, hey, come on, let's go. We got something to do. And then it's going to release the breakdown of that glycogen that's stored there, turn that into glucose, and then use that as the cellular energy, okay? It's also going to stimulate the liver and the kidneys to produce glucose from non-carbohydrate molecules, okay? The problem with that is non-sustainable, okay? That's why they always talk about complex carbohydrates, right? If you want complex carbohydrates, not your simple carbs, because if they're complex carbohydrates, there's more for it to grasp onto. There's more moving pieces to it. There's more pieces to the puzzle, and it's harder for the body to break those down as fast. Whereas a simple carbohydrate, we knock that out of the park real quick, and then we're back in the same boat we were just in, okay? Whereas if you throw some complex carbs at it, it's going to take a little bit longer for them to, it's complex. It's like between like a simple 2 + 2 or some trigonometry, simple, complex. What's going to take longer, right? Another important function is the activation of hormone-sensitive lipase, I think is how we say that, which breaks down the stored triglycerides into free acids and thus free fatty acids, and thus converts them into ketones. Okay. All right. So pathophysiology of diabetes. So we've given you all the puzzle pieces, and this is how it does not fit together. When insulin is not being produced, like we said, when it's not working or it's not being produced either way, or the cells become resistant to it, like I said, they're not working, the blood sugar levels will rise. Okay. If the insulin's not working, then the sugar's just going to keep going up and up and up and up and up and up. All right. And this is going to lead to a situation where the body is unable to metabolize the sugars. Not a good scenario, right? So if unchecked, it's going to wreak havoc on many different systems over time. We'll kind of talk about those systems as we dive into this a little bit more, but everything works together, right? All these organ systems and all these body systems, if something's faulty in one of them, it's going to end up affecting the other, right? It's funny how all that works. It's got diabetes, excuse me, has two primary causes. You've got type 1. It's when the beta cells are damaged or destroyed and insulin production is limited or not present. So you've got a lack of insulin. Okay. So these are going to be your insulin dependent diabetics and ones that they don't produce it, or they do and it just, it's not enough, or, but it's not that there are some present and they don't work, right? This is an organic malfunction in which the insulin's not produced. And then you've got type 2. This is an exaggerated cellular resistance to insulin being that is produced. Sounds awful, right? So it's often related to poor health choices. It's all those Big Macs, all those milkshakes, all those cigarettes, all that, it's the 6-pack of beer every night. That's what's doing the damage and getting these cells resistant to the insulin. All those poor health choices, not being, physically active, you name it. All those that general health, that all ties into this and how we react every day to everything that we eat. And odds are those people that don't really take good care of themselves are the ones that are in the Taco Bell and the McDonald's lines every day, right? That are eating these fast food restaurants, which they've got their time and place. Like, I like a good Big Mac every once in a while too. Don't get me wrong. They're great, but man, you know what it is, right? You know what it's doing. So, be smart about it. But we know we've got so many type 2s that are out here and then they're getting younger and younger. All right. That's a problem. We've got to rectify that. We've got to correct it. We've got to fix this somehow, figure out what we're doing here. All right. So type 1, let's get into that more. It's going to be like your juvenile diabetes, right? So generally it's going to strike children as opposed to adults. They're born with it a lot of times. Okay. It's often going to present with your general malaise. They're always tired, like just tired. Like, why is this kid tired? What is going on? Excessive thirst, excessive urination, and dehydration. That's all kind of like a tricky equation right there. That excessive thirst, urination, and dehydration. So they are urinating like crazy. Have you ever witnessed like a diabetic urinate? It is, they will go for 2 minutes. Just a constant urine for 2 minutes. That's the body trying to get all that sugar out, right? It's say like, well, we can't process it on the cellular level, so let's go ahead and just excrete it how we know how to do all the other toxins. Pee, right? So you're peeing, you're going. And because it's trying to expel all that excess sugar, all that excess stuff that is not able to be processed because of the lack of insulin, right? So we're not able to keep up with how much we're drinking in comparison to how much they're urinating, and then become dehydrated. Okay. So it's a never ending story there. Hereditary disposition to the disease. Typically, if one of the parents, suffers from diabetes, the kid has got a higher chance of it than someone, like me or my wife. Neither one of us are diabetic. So, say if one of you guys are diabetic and your wife isn't, y'all's children will have a little bit higher disposition to be diabetic than what mine will, because it is an hereditary issue, right? Type 1 is, it is what it is, right? We can't do much about that because we're born that way. Whereas that type 2, we've got some control over. Okay. These kids have to, they don't produce insulin, so they rely on insulin injections. Have to take a couple a day. They've got several different options now. They must follow strict dietary guidelines in order to limit sugar and carbohydrates. It's going to be especially challenging for your pediatrics. And this is juvenile diabetes, right? Great example here. My wife is a school nurse. Okay. She worked for 2 years at the junior high. So she had a dozen diabetics. All right. She had several diabetics. And I'm talking, there were some students that were, ranged from 40 to 400 in a day. The same patient, on a low end would be in the 40s and on the high end would be in the 400s. And it's like, oh my gosh, like, can you imagine like what their blood panel would look like, oh man, like it is probably it's probably mayhem in their blood right now. So they've gotten so many technological advances now. Most of these kids had some type of internal monitor that was Wi-Fi, Bluetooth, all that good stuff. And so they would just add my wife to their profile, right? And she would get alerts on her phone if they were to go outside of certain parameters, right? Go either low or high. It would alert everybody on their profile, mom, dad, nurse, her, whoever it is. But it would alert them and they would know like so-and-so blood sugar is this, and so that was really good because you kind of get a real-time view of what's happening, right? So you can correct it as soon as it starts trending one way or another if need be. But man, talk about like that's a job on us in itself. I mean, us as EMTs and paramedics, we're not really taught too much about insulin and how to administer it, right? That sliding scale is no joke. Like, she's tried to explain it to me a couple times, and it's like all dependent on what carbs they eat, blah, blah, blah. And it's like, what? And you're talking about a kid who may say like, oh yeah, I'll go eat this, and this, and then go buy some nachos and some sweet tarts. And that's what they had for lunch just because that's what they feel like eating. I mean, not only do you have such a wide range of where you're at on what side of the spectrum, but you've also got the aspect of these kids don't really grasp how serious this is yet. They don't comprehend all the way that, man, this is real. I've got to, if I don't pay attention to this, I'm going to lose my foot by the time I'm 30. Right. They don't understand that. And unfortunately, a lot of times it doesn't happen until there's some type of irreversible damage. So, the better educated these kids can be on this, man, the better off they are going to be when it's all said and done. All right. Type 2 diabetes, Big Mac diabetes. This is going to be adult onset. All right. So 90% of all diabetic patients in the United States are type 2. Develop later in life with increasing child obesity. There are more younger patients being diagnosed. For instance, I know like when I went to paramedic school and EMT school, normal blood glucose levels were between like 70 and 100 or 80 to 110. Like that was kind of like your normal parameters. Now, I think anything, a hyperglycemia is fasted over 130, right? Like we are just not as healthy. We're just gradually getting more and more unhealthy. It seems like in some aspects of this, medicine is advancing and like we are getting more obese, it seems like, so we've got to keep up. We've got to, at a certain point, care about ourselves and understand that like this is self-inflicted a lot of times. So, and now it's getting to the point to where it's not even self-inflicted when it comes to these kids. Some of these kids can't feed themselves. They can't cook yet. They're too young. But whenever you've got an 11-year-old that is, clinically morbidly obese, where are we looking at who to put the blame on at this point? Right. So definitely something that needs to be addressed. Insulin resistance is a characteristic of metabolic syndrome, as well as hypertension, hyperlipidemia, and obesity. These increase the risk of heart disease, stroke, and type 2 diabetes. All right. And then let's get into gestational diabetes. Okay. Not uncommon. This is a pretty common one as well. Expectant women sometimes develop diabetic symptoms during their pregnancy. So during the pregnancy, the fetus requires glucose for energy, right? It's a human. It's a thing that may look like an alien, but it's not. It's actually a human, which is supplied by the mother's circulation. Okay. So it doesn't have its own blood circulation yet until the baby, it sounds so bad, until the baby is out into the earth and open air and starts breathing and starts producing that gas exchange on their own, that alveolar gas exchange, that CO2, O2, all that good stuff. Until they start doing that and perfusing on their own, they're using the mother's blood supply, right? That's what the umbilical cord is. Makes sense. All that good stuff's all in there. So during the pregnancy, the baby is using the mom's blood supply. So in turn, that's why the pulse rate increases a little bit. blood pressure drops a little bit, all that good stuff, because they don't really make too much more blood. I mean, blood production, it ramps up a little bit during pregnancy, but not like that, So the body's going to compensate how it knows how to and how it's supposed to. The mother's physiology must adapt, obviously, to the increased demand for glucose. It's got a whole other being that it's got to produce glucose for and to energize. Okay, so there's a new demand for it. There's a little bit higher demand, obviously. So the mother has to adapt to that. Normally, the pancreas will secrete more insulin, and the maternal cells show decreased sensitivity to it. All right, so that's typically how it's going to adapt and to stay in normal ranges. But if not, if they cannot maintain homeostasis, they're going to develop gestational diabetes. All right, meaning that blood sugar is going to be high. Okay, it's going to be higher than usual because the insulin is not working as much. It's a little bit resistant because secondary to the increased demand of glucose. Right, so it's funny. I mean, I'm not a woman, so I've never been pregnant, but like watching my wife have both of our children, the changes that the woman's body goes through in that 9 months, but it's a short amount of time in the grand scheme of things. Wow. Like, how is not every woman gestational diabetic? I mean, how could you not be? I mean, within that short amount of time, you've got to flip the script and your body's got to figure out exactly how to do that. Man, this is complex. You know what I mean? So it's not uncommon. My little sister had gestational diabetes. My wife was on the cusp with both of our children, but she actually with our second one, she wasn't. She gained like 10 pounds. But she was one of those ones. She's in the gym every day. She runs like 20 miles a week. Day-to-day management of diabetes. All right. So patients whose pancreases do not produce insulin must take subcutaneous injections multiple times throughout every day in order to maintain normal blood glucose levels. Insulin is classified by its onset of action. You've got your short acting, intermediate acting, and long acting. We talked about that long acting in our case study, right? That 32-year-old took Lantus, which is a long acting insulin. So right off the bat, it was okay. He didn't feel bad when he went to bed. He didn't eat dinner. He worked through dinner and he took his insulin, took his night meds like he was supposed to. And when he went to bed, it felt fine. And that's because it was extended release. And so throughout the night, his blood sugar just gradually got lower and lower and lower and lower because the insulin was working how it was supposed to and did not have enough glucose or sugars to turn into glucose to you know what I mean? So you're just getting lower, lower, and lower, and lower, right? So you've got to know what type of insulin you're working with whenever you come across these patients. Okay, kind of be familiar with which insulins are doing what. Are they short acting? Are they intermediate? Or are they long acting? Many diabetics are going to take a combination of all three types. And they've got some type of cocktail that the doctor has drummed up for them, all dependent on the patient. It's going to be patient specific. All right, insulin pumps, very popular. They're becoming increasingly popular. I had a coworker, another paramedic that I would work with. His name was Charlie. And when Charlie we're here in Texas. Okay, so we're deep south. Fried food is good, but there's so many diabetics here, right? So he's got an insulin pump. All right. So when we go to our local diner at work, the one that lets you eat for free, and so we're there all the time, right? They had like chicken fried steak that day. So we walk in, and next thing you know, you can hear Charlie behind you, and he's hitting doop, 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 doop. He's hitting the bolus button on his insulin pump just because he knows he's fixing to smash on about 2 or 3 chicken fried steaks, mashed potatoes, fried okra, all that good stuff. Unhealthy meal. And he knows what's fixing to happen. So he goes and heads and hits that button a time or two just to go ahead and combat that. Where it gets tricky is whenever that infamous dinner time tone goes off, right? When he gets his plate after he's hit the button a couple times getting ready, and then he sits down with his chicken fried steaks and tones drop. Okay. And then now we're on the side of the road with an MVC, and about 30 minutes later, he's like, oh no. And he can feel it. He's a career diabetic, but he knows exactly where he's at. And so he'll look down and he'll say, oh, I need to get something to eat. And, we're working a call and his blood sugar's 30. He's 36. And it's like, oh my gosh, Charlie. So we got to go feed Charlie. Somebody go take Charlie and get us some crackers. You know what I mean? But they're very popular. They give you a real-time level or measurement of what the blood glucose is and will titrate or bolus that insulin continuously from a reservoir to keep those levels where they're supposed to be, right? The problem is when you hit the button to bolus it whenever you need that extra hit and you don't eat, you don't eat in time. It's happened a couple times to us, but it's not really something you can help other than just not hitting the button or eating crappy. But here we are. Long-term complications of diabetes. So long-term complications of diabetes can cause a dysfunction in a number of different organ systems. This disease process can be divided into two subcategories. You've got microvascular. This is complications which include neuropathy, nephropathy, and retinopathy. I'm sorry. That is the most common long-term complication of diabetes are going to be your microvascular. Okay. Macrovascular are complications that include the cardiovascular disease, stroke, and peripheral vascular disease as well. Okay. So a little bit more intense as far as complications go. Not as common as your microvascular, but they're definitely out there. Okay. And we'll get into some examples of these, as we go on here. So, diabetic peripheral neuropathy. This is something we see a lot, isn't it? I mean, this is kind of something that it's a bad side effect of diabetes. Whenever you don't take care of yourself, this is coming eventually if you're bad enough off. This is a progressive microvascular disease that's estimated to affect 30 to 50% of diabetic patients. Okay. 30 to 50%, almost half of your diabetic patients have some type of microvascular, diabetic peripheral neuropathy. Okay. Primary risk factor is chronic hyperglycemia, as well as the patient's age, duration of the disease, how long have they been diabetic, cigarette smoking, hypertension, elevated triglycerides, higher body mass index, alcohol consumption, and taller patient height. It typically presents with pain, numbness, and tingling in the extremities that worsens over time. My wife had a patient or a student last year at her junior high. She's at elementary school now. She's got no diabetic patients, so that's comforting. But at the junior high last year, she had a girl that when her blood sugars got up real high, when they were above like 300, she couldn't feel her right hand. It's like, man, you're 12 years old. So you can imagine that by the time, if she doesn't take some very major corrective actions, she might not have that hand for very much longer in her adult life. If at 12 years old, she's already starting to show signs of DPN. But that's something that, something that we see. All right. Other common complications we're going to run into. They've got 10 to 20 times more likely than non-diabetics to have a lower extremity amputation. And that's because of that neuropathy. Okay. That's because of that decreased blood flow and decreased circulation in those extremities. Approximately 150,000 people in the United States have end-stage renal disease as a result of the diabetic nephropathy. So, you've got some internal issues with the renal failure and things like that. Now they're in dialysis. Diabetic retinopathy affects 10,000 new cases of blindness every year. Right, so 10,000 people have some sort of blindness due to this. That's profound. Cardiovascular disease is the case of death or cause of death, for as many as 65% of patients with diabetes. And then patients with diabetes are 2 to 4 times more likely to suffer strokes than the general population. All right. And we learned that when we learned about strokes. I mean, your diabetic patients are, they are at higher risk of having strokes, and they have the silent MI, right? That's your typical silent MI patient is that 40-year-old female that is diabetic, is having nausea, right? That's always your sneaker. All right, hypoglycemia. It's the most common endocrine condition in emergency medicine. So common, it's protocol to obtain a blood glucose test when any patient presents with altered mutation. Some services want one regardless of a history of diabetes. You don't even have to be diabetic. You don't have to have a history of diabetes. They want one on you no matter what. Right? That's how some protocols are driven. In the early stages, these patients may exhibit a sympathetic nervous system response such as diaphoresis, tachycardia, and anxiety. And if the blood sugar continues to drop, then confusion, unconsciousness, and then seizures, and eventually death will follow. These patients present with slurred speech and unilateral hemiparesis that can appear like a stroke. Okay, can also be present as combative or violent. All right, that's not uncommon. If their sugar's low and they're altered, they can be violent. As soon as you get the sugars up, 9 times out of 10, they're good though. Okay. One quote I like to say all the time: cold and clammy, give me candy. Warm and dry, sugar's high. All right, remember that. That's a good one. That's a good way to remember where you're at. You can look at a patient, kind of see that skin color and condition, and you see hypoglycemic. We've got diaphoretic, tachycardic, and anxiety. So cold and clammy is diaphoresis, right? Clammy. So cold and clammy, give me candy. Warm and dry, sugar's high. All right, remember that. That has one thing I remembered since day one of EMT school that I'll never forget my entire EMS career. All right, so treatment of your awake hypoglycemic emergency. All right, so scene safety. Once a patient's blood sugar is low, they may become aggressive or combative. I know several patients that are in my district that, when we go to their address, we're like, oh boy, here we go. But as soon as we get his sugar up, he's the nicest guy in the world. Law enforcement. You got 2 things you need to worry about here. First being make sure that the scene is safe and they've got your back in case you start to get your butt whooped. 2 is make sure that they're aware of what capacity they need to be there in. Okay. And when I say that, I mean, we don't need handcuffs and tasers and batons to a hypoglycemic emergency. All right. We need you to, if anything, kind of restrain this patient to where we can administer some glucagon if we've got to, right? To where we can get that sugar up. But be there so we don't get hurt, but also don't hurt this patient because this patient's not a criminal. They're having a medical emergency right now, right? Oral treatment is acceptable if the patient's awake, alert, and adequately able to protect his or her airway, able to follow commands. Then we can give some oral glucose, cake, icing, whatever the case may be. If a commercial product's not available, then any food or drink that's high in sugar is acceptable. Takes about 8 ounces of soda to get 25 grams of sugar to the patient. And it's going to take a little bit because it's got to digest, right? It's got to break down in the stomach and all that good stuff. It's going to take longer for the patient to absorb it when it's taken orally. If the blood sugar begins to rise, encourage them to eat a full meal with protein and complex carbs. We've kind of beat that into the ground now on why. The simple sugars in soda, candy, and oral glucose will metabolize quickly because it's simple. And eating a meal will help to prevent that rebound hypoglycemia. All right, so for your altered hypoglycemic patients, so these patients that have altered mentation, if they have altered mental status or is unresponsive, we're going to need to manage their airway, breathing, and circulation. Start with your BLS techniques first, okay? We don't want to intubate these diabetic patients because if we fix the blood sugar, they're going to wake up, right? And if we've got them intubated and they wake up and they start ripping things out of their mouth, they can do a lot of trauma. All right. If they're hypoxic or experiencing hypoglycemia, support the airway and assist with ventilations if needed. BLS, right? Let's start basic. And if we can fix it with that, leave it alone. Intubation should be avoided until after an attempt to correct the hypoglycemia has been made. If the patient is intubated, then wakes up, like I said, they can attempt to yank out the tube and do some airway trauma. Okay. Hyperglycemia. So it's a fasting blood sugar greater than 130. It's caused by excessive food intake, insufficient insulin, infection, illness, surgery, and or stress. If a diabetic patient eats a large sugary meal and does not take insulin or any other anti-hyperglycemic medication, then his or her blood sugar glucose or blood glucose will rise, or it's going to increase. If left untreated, we can go into DKA or diabetic ketoacidosis. All right, and we're going to jump into that right now. All right, so DKA. This is the extreme end. And there's actually more than that. You've got HHNK, which is even higher than DKA, but that's for another day. So DKA, without insulin, the cells of the body are unable to metabolize the glucose that is available, and they begin to starve. Okay, so the cells are going to break down the proteins into amino acids, then lipids, into fatty acids, and oxidize ketones. Ketones is never a good word, right? It's usually always associated with something's not working right or not happening right in the body. And so now there are ketones, right? When you hear ketones, red flag, okay? This leads the patient to a state of metabolic acidosis. DKA causes excessive urination, which leads to dehydration. We talked about that chain of reactions already, right? Some symptoms we're going to come across in here are going to be altered mental status, weakness, visual disturbances, nausea, vomiting, polyuria, polydipsia, abdominal pain, tachycardia, flushed dry skin, warm and dry, sugars high, fruity breath, and Kussmaul respirations. Why do they have a fruity breath? Why do they have fruity breath? So we talked about those ketones, right? So those ketones, they're trying to expel them somehow. They're going to get rid of them. So those times when you get called to a possible drunk driver that's just acted funny, maybe they're overdosed on something, and you get there and you can smell their breath and it smells like a vodka cranberry, check that blood sugar. Because it might not be the vodka cranberry. It might not be that fruity alcoholic drink. It may just be the ketones on the breath trying to get that blood sugar down. Okay. Then you've got somebody, a DWI, that doesn't deserve one. All right. Treatment of the hyperglycemia. Primary treatment is going to be insulin. We can't really do that. All right. We don't know what their scale is. We don't know what their cocktail is. We don't know what that slide scale or mixture or any of that is. So they don't really let us play with that too much pre-hospital. It's typically administered in the hospital setting as opposed to in the field. With some symptomatic hyperglycemic patient, focus on supportive care and aggressive rehydration. Essentially, what we're trying to do is to dilute the blood and to get that blood sugar down. If we can get enough fluids in there to try to get, dilute it some and get that blood sugar concentration down. Airway support is important for those patients without adequate respiratory drive. And remember, these patients are in a state of metabolic acidosis. The respiratory rate is going to be elevated, which will show as a decreased CO2 level via capnography. Okay. All right. Conclusion for this first one is going to be medical or emergency medical personnel will respond to a multitude of diabetic emergencies. These calls can be challenging when you have an aggressive hypoglycemic patient or a severe DKA patient that's unresponsive. Diabetes, especially type 2, is a growing problem in the general population. It's a growing problem among EMS providers as well. Those 7-Eleven diets that we're on, not good for us, right? All those Allsup's burritos if you're here in Texas. We owe it to ourselves, our families, and our patients to do everything we can to prevent health problems in ourselves, like type 2 diabetes, okay? So that's pretty much it as far as diabetic emergencies go. I hope you learned something a little bit. We got some good information out there. All right. You guys have a good one. And let's move on to this next slideshow. All right. So next up, we're going to be going over anaphylaxis and allergies, or allergies and anaphylaxis. Okay. So objectives that we're going to cover in this one are going to be describe the basic anatomy of the immune system and its overview and the overview of its functions. We're going to list common causes of allergies and anaphylaxis. And we're going to describe the physiological process of allergies and anaphylaxis and identify and treat a patient with signs and symptoms of allergies or anaphylaxis. All right. So case study on this one. We're going to have a middle-aged male complaining of eyes watering, itchy throat, and several rashes appear on the patient's face, neck, and arms. Okay. Let's go back into this little backstory here. Okay. So you're a paramedic. You're in paramedic school, right? You are at your psychomotor skills testing day. And they have invited several external instructors and other paramedics and stuff to come in and assist with the skill evaluations, right? One of the instructors tells you ahead of time that they are allergic to latex. All right. Knowing that latex allergies are common, your school stopped using products containing latex a long time ago. All right. But training sessions go throughout the day is uneventful. It's now time for the capstone patient scenario. Instructors volunteer to be mock patients for the students. All right. So this instructor that's got a latex allergy is one of the patients now. A few minutes into the patient scenario, the instructor who is allergic to latex stops the scenario and asks you if there is any latex in use. Okay. The student that is treating the instructor says that she was wearing latex gloves earlier, but the student continues to explain that she prefers her own gloves to the ones supplied by the school. But since she knew that he was allergic to latex, she took them off and was using the school ones, right? It turns out that the mere fact that the student had worn latex gloves was enough to trigger an allergic reaction in this person or in that instructor. The instructor's eyes start watering. Like I said, we've got eyes watering, itchy throat, and several rashes appear on the patient's face, neck, and arms. The patient's really good and really adept to managing, his condition. He knows that he's allergic to this, so he knows what he's got to do. So he goes to his bag to get his Benadryl and asthma inhaler. All right. So by the time he gets there, though, he is now experiencing difficulty in breathing, and he's unable to swallow the tablets of Benadryl. And so he cannot take the Benadryl, and he's having difficulty breathing. All right. So it's not gradually, but it is rapidly getting worse. Right. So what are we going to do? We're going to put this patient into supine position and obtain vital signs. So when we first get on scene, we've got 102 beats per minute as a pulse. Respirations are at 22 breaths per minute. Blood pressure is 109/68, and pulse ox is 92%. Okay, so it has to do maybe with this difficulty breathing. The patient, who is, like I said, well-versed in his treatment, hands you his EpiPen. All right, you look at it, you do your 5 rights, 6 rights, how many rights there are for your drug administration. You do all those, and you immediately inject it into his anterior lateral thigh. All right. The patient is then placed on nebulized oxygen with albuterol and ibupropion bromide or Atrovent to help with the wheezing, right? So we've got difficulty breathing, we've got bronchoconstriction. So here we go. We're going to throw a neb at it and do a neb. IV is set up, and we're going to administer Benadryl IV or diphenhydramine. You're going to follow your local protocols on treatment of allergies and anaphylaxis as far as that goes. Typically, it's going to be like about 20 to 25 milligram IV push of Benadryl just for your run-of-the-mill allergic reaction, right? All right, so you give that neb treatment, you give that Benadryl and supportive care to the hospital. End up, your protocol may call for some, different corticosteroids or things like that to kind of help with that difficulty breathing. But end up sending the instructor by ambulance to the local emergency department. He was evaluated and treated and released and came back saying he just wanted to make it more real for all the students. Right. So, ended up being okay, but was a little bit of a scary moment there for a little bit. All right. So allergy and anaphylaxis, we're going to jump into the introduction of this. All right. So allergies, it's going to be an abnormal reaction to our immune system that occurs as a result of the presence of an otherwise harmless or benign substance. All right. The benign substance is treated by the immune system as a threat. All right, our body just thinks, oh, no. And it's a threat to the body. Many histamines, along with other mediators, are released to fight off that threat. This causes an inflammation of the mucous membranes, increased mucus production, rash, hives, itching, swelling, and difficulty in breathing. More severe reaction is going to be known as anaphylaxis. Okay, and we'll get into that. All right, so an allergic reaction. What is this? In most cases, it's nothing more than a nuisance and triggers some mild symptoms. You may get a runny nose, your eyes might water a little bit, get a little bit of sinusitis and other cold-like symptoms, okay? If you're here in Texas, pollen season, perfect example. You get all of these symptoms, 3 months out of the year, every year, right? Because you can go outside and write your name on your window because the pollen is so thick. But here we are. Anaphylaxis and anaphylactic shock. So sudden severe systemic reaction that involves 2 or more body systems. That is the definition of anaphylaxis. Okay. So allergic reaction, nothing more than a nuisance, triggers mild symptoms. All right. You've got one of these. You got a runny nose. All right. Your eyes are watering, you've got whatever. 2 or more body symptoms, meaning, all right, I have a rash and my nose is running. Anaphylaxis. Okay. 2 or more body systems that are involved equals anaphylaxis. This results in dizziness, nausea, syncope, and a sudden dramatic decrease in the patient blood pressure, as well as a probable respiratory compromise. I was taught anaphylaxis means airway involvement. All right. They have since gone back and retailored that definition, and it is 2 or more body systems. Now, if left untreated, anaphylaxis, it can quickly lead to anaphylactic shock. Okay. That is a life-threatening medical condition that includes bronchoconstriction and cardiovascular shutdown. So now anaphylaxis is two or more body systems, and anaphylactic shock is bronchoconstriction and cardiovascular shutdown. Okay. So obviously your more severe is going to be your anaphylactic shock, but that definitely has got airway involvement. All right. I say all that 99% of the time, if you've got multi-system involvement, one of those systems is going to be breathing. Okay. That's just what it is, but it doesn't have to be. Okay. 40 to 50 million Americans suffer from some form of allergies, with 29,000 anaphylactic reactions occurring in the United States each year. All right, so basic anatomy. So the human immune system protects the body against infection, injured tissue, cancer, and other harmful substances. We've got several different defense layers intact or in place that do this. Okay. The body has developed several defense systems to negate these threats, and our immune system is the primary defense network. Our immune system is a complex and diverse network that's got defense components in the circulatory, integumentary, digestive, lymphatic, respiratory, and skeletal system. So it's got its fingers in every single pot it can be in, right? It's a part of every game. It's like the all-time quarterback. Within these systems, there are layers of protection: mechanical, chemical, and cellular. All right. So some terms that we need to know: hypersensitivity. This is any response to the body to any substance to which the patient has increased sensitivity. All right. So all allergies are hypersensitivity, but not all hypersensitivities are allergies. You get me? Doesn't have to be an allergy just because you have an increased sensitivity to it. For instance, I mow the grass. For some reason, freshly cut grass, I'm hypersensitive to. All right. I don't really. Where do we make that correlation with an allergy and a hypersensitivity? I'm with you. Your guess is as good as mine. But they say it's not an allergy. All right. So I don't take a Benadryl before I go mow the grass because I'll fall asleep on the lawnmower. But I do have some type, I can tell a difference. All right. Not really. I don't have a runny nose, but it gets a little stopped up. You know what I mean? Like where I'm like, I'm not breathing as easy as I was. That I think maybe would be, your correlation there. But technical definition, hypersensitivity versus allergy is a good one there. An allergen, any foreign substance that triggers an allergic reaction in a person. So it can be anything, including food, chemicals, plants, insects, and medications. Generally harmless to people, but some could possibly die from the same exposure. All right. So like I love shrimp, but don't give it to my son because he might die. He's 2. He had a rash one time we gave it to him. We haven't tested it since. I hope he's not allergic to shellfish because poor guy, man. Antigens, substances that the body will recognize as being foreign. Once recognized as foreign, the immune system is going to generate antibodies with the intention of helping to fight off or destroy that antigen. All right. This is like your soldiers. Okay. So your antibodies are going to be markers that help the immune system identify those antigens. The antibodies are what, antigen is not your soldiers. The antibodies are. I'm sorry. I wanted to make sure I clarified that. Most are found in the plasma. They make about 20% of the plasma proteins in a healthy person. They mark the antigens through 3 different mechanisms. The antibody will coat the antigen with effective labels, which effectively labels them for removal. It's got some type of coating on it that's like, different color than everyone else's. And they're like, not that guy, can't sit here. And, let's get him out, right? Will cause the antigens to stick together and form a mass. So they coagulate. Everything that you don't want gets it all kind of stuck together in one just big ball of bad, and which aids in eliminating the antigen, or bad, I should say, right? Then the antibody plays an active role in activating or inactivating certain bacterial toxins, which also aids in the elimination. All right, so your different types of allergic reactions. They can cause local or systemic reactions. All right. So your local reactions are going to be limited to the area that is exposed to the antigen. So like grass, right? I'm allergic to grass, or I'm allergic to hand sanitizer. Okay. Or some type of chemical in the hand sanitizer. And I use the hand sanitizer and my hands turn red and they're itchy. Okay, but that's it. All right, so that's local. Rash to a cream that he or she rubs on their face only occurs when the cream is applied, right? That's local. Whereas a systemic reaction involves the widespread release of a large number of histamines throughout the body. Far more severe than local, obviously, right? Because it's involving the whole body instead of just your hands or your face or whatnot. Stung by a bee on the foot presents with a swollen tongue, difficulty breathing, and breaks out in hives, right? We're in anaphylaxis. Actually, that's almost anaphylactic shock at that point. But that's far more severe than just, an itchy face because of some cream that I used. All right. So 4 types of hypersensitivities. You've got an allergic reaction, which is an abnormal response in the immune system to an allergen, an antigen that causes an allergic reaction that a patient has been previously exposed to. It can be local or systemic, like we just talked about. May require emergency medical treatment, or many can self-treat. Just take some Benadryl, maybe EpiPen if need be, and they're good to go. Anaphylaxis is a severe allergic reaction that is systemic and involves 2 or more body systems. Without treatment, will lead to respiratory collapse and death. We have got to treat this. We have got to fix this. It's not going to fix itself. It's not self-correctable. Biphasic reaction occurs when reactions that occur 8 to 11 hours after the successful management of the first reaction. So we've got the first initial reaction, we treated it, we were good to go, and then 8 hours later, boom, we're back in it again. It's going to be a biphasic reaction. Occurs in about 20% of your anaphylaxis patients, okay? It's only fatal in 4 to 5% of those patients, though. So 20% of them will have it, but only 4 to 5% of those will be fatal. All right, so a little comforting there, but it's still something we definitely need to know how to treat or look out for. This is why it's important for anyone who has suffered any type of severe allergic reaction to go to the ED for evaluation. Prolonged reactions are a rare instance where anaphylaxis can persist up to 72 hours, unlikely to be fatal at that point, okay? All right, so some defense layers that we've got. We've got the integumentary system. That's going to be the largest system in our body that provides the first line of defense. In addition to regulating our temperature, our intact skin serves as an effective mechanical barrier to many pathogens. Our defenses may be defeated by a compromise in the skin, such as an injury, or through a natural opening like your ears, nose, eyes, mouth, the normal holes in our skin that are supposed to be there. The next layer of defense is chemical forms, such as tears, saliva, mucus. Tears and saliva clear away those pathogens, while mucus traps them where they are, like keeps them right there, coagulate, leave them alone. Don't travel any further as they attempt to invade our bodies. All right. So your common allergy causes: arthropods, myriapods, arachnids, insects, crustaceans. Your myriapods are going to be like your centipedes, millipedes, your creepy crawlies, right? Arachnids are also gross, disgusting. They're spiders. Brown recluse, black widows, ticks, mites, things like that. Insects. Fire ants, wasps, bees. I got tagged last time I got stung by like 5 yellow jackets, like in the ear and the face. I feel like next time I get stung, it's gonna be a little sketchy. I don't know, because like I blew up, I look like Hitch, like Will Smith. I mean, it was just, but yes, we'll see. And then crustaceans. Allergic reactions occur after ingesting crustaceans like lobsters or shrimp. Shrimp is the leading cause of allergic reaction. Should a person ingest one, or if merely cross-contamination, anaphylaxis can develop quickly. My son. Plants. Allergic reactions to grass, weeds, and trees are typically caused by the pollen or the other airborne particles. And I don't know anyone that's not allergic to pollen. All right, I feel like 100% of the human population is allergic to pollen. It's awful. This is prevalent during the spring and summer months due to the warm, dry, breezy weather. You see a lot, like here in Texas, you could be, I golf a lot. So like I'll be out on a golf course and like a big, strong wind gust will come, and you could just like look off in the horizon and see a cedar tree, and just, it looks like a dust storm come off of the tree. And that's just all pollen. Like that's just all runny nose. That's all that is. It's just runny nose. And it's yeah. Ugh. Small percentage of the population can acquire contact allergies from plant products such as sap from the rubber tree. It's used to produce many rubber products, including latex, which can be found in a lot of things today. Animals. Your household pets going to be the number one cause of animal allergies in the world. 10% of the population has some type of animal allergy. They tend to be genetic in nature. Not all the ways though. Like I'm not allergic to cats, but my dad is, right? But I'm okay around. I don't have any cats just because like you can't trust cats. But other than that, like, I mean, I'm not allergic to them though. The misconception that people are allergic to the animal itself when the allergies are actually caused by the animal's saliva, urine, or dander. That could be pet specific or species specific, right? So like dog saliva could not bother you, or dog hair or dander could not bother you. And then you get a cat and they lick you with their sandpaper tongue, or they get hair everywhere, and then you are in a world of hurt, right? You're allergic to cat dander. So it doesn't have to be both or all. That's not an all or nothing deal. And nowadays they've got those designer animals out there that are hypoallergenic, things like that. So the options are limitless. Other causes: medications, antibiotics, pain medications, etc. Some meds like propofol are made with egg and soy components. This is why it's super important to know the patient's allergies to include food allergies prior to medication administration. IV contrast for CTs usually contain some type of iodine. And then blood products. Those, you could be allergic to another type of blood. That's why we always have, if we're administering blood pre-hospital, if we're doing a transfer or something like that, we've got 2 ports, right? You got a Y system. That way you could cut off that blood and run saline if you need to flush that out. A lot of times you've got Benadryl on hand in case you've got some type of reaction. There's a lot. It's not as simple as like, oh, let's just hook it up and let it run. We got to make sure that the body's going to accept it, right? Chemicals, hair dye, laundry detergent, cleaning items, etc. Things like that. I mean, you can be allergic to anything. Physiological process. There's going to be 4 main ways an antigen can enter our bodies: inhalation, ingestion, absorption, and injection. After exposure, the body creates antibodies or markers that are specific to that antigen. This is going to help the immune system identify these antigens in the future. So immunoglobulin E, or IgE, are the antibodies that are associated with an allergic reaction. It only makes up less than 1% of all antibodies. IgG are found in all body fluids. They are the smallest but most common antibody. This is the only antibody that can cross over the placenta to protect the baby during development. All right, so that's pretty important, right? That's the fighter for the baby. And then IgM are the largest antibodies and are the first type to be made in response to an infection. All right, those are kind of like your pawns, if you will. They send those guys out there knowing what their fate is. But it gives us the chemical marker we need in order to create IgG and IgE, right? Physiology of allergies and anaphylaxis. So when our bodies overreact to the antigen, a large amount of the IgE antibodies are released. Once the basophils or mast cells are located in the IgE antibodies, those histamines and other chemical mediators are released into the surrounding tissue, right? So it's releasing that surrounding tissue, and thus it's going to overtake all that antigen that's there that it has deemed that it needs to take out, right? Once the histamines are released, they're going to attach to 4 different histamine receptors. The 2 that are most concerning for us are going to be H1 and H2. H1 causes smooth muscle constriction. All right, so more specifically, bronchoconstriction and constriction of the intestines, which cause abdominal pain, right, and difficulty breathing. And then H2 causes peripheral vasodilation. So when the vessels dilate, this decreases the blood pressure, and the patients can also have a reddening of the skin or a rash. And if these 2 things happen together, bronchoconstriction and peripheral vasodilation, you can imagine how that mismatch would be catastrophic, right? All right, so treatment. So depends on the severity of the reaction. Are we mild to moderate or severe to anaphylactic? Okay, so they're treated very similar, but if it's anaphylaxis, epinephrine should be the first med given. And we also are going to give some oxygen, antihistamines, and but we're giving epi first. Antihistamines, these drugs do not stop the histamines from being released, but what they do is they block the receptor so those histamines cannot attach to them and give you that reaction, right? That H1 or H2 reaction that we don't want. Epi, it mimics the sympathetic nervous system, which will cause vasoconstriction. So you've got that peripheral vasodilation. You push that epi, it vasoconstricts. Okay, increases the blood pressure, dilates the pupils, and reverses that bronchoconstriction. Okay, and decreases the production of the gastric fluid. So it's kind of pretty much the end all fix all for that H1 and H2 reactions that we don't want. Mild to moderate. Ensure the patient's airway is patent. Provide oxygen via appropriate device. We're going to consider epi if they have a known allergy to the antigen. If using a prescribed EpiPen, make sure you go over it, make sure it's theirs, it's in date, it's not contaminated, all that good stuff. If no prescriptions available, epi 1-to-1 going to be 0.3 to 0.5 intramuscularly every 3 to 5 minutes. All right, one thing that they like to say is 0.3 saves everyone, okay? Because that is the low end of your adult or high end of your PD. Or so, low end of adult, high end of PD would be 0.3. So 0.3 saves everyone is a good thing that you can remember. Consider the use of bronchodilators to assist with the opening of the airway. All right, severe allergic reaction to anaphylaxis. This reaction is going to rapidly develop. These patients develop the feeling of dread and doom. Their reaction will normally be systemic, meaning there's going to be multi-system involvement. It can cover the body in a rash, cause difficulty breathing, potential shock, vasodilation, bronchoconstriction, all that good stuff. Patients should receive the same medications as mild to moderate with the addition of supportive care for shock. So these people may need some type of supportive care as far as like epi drips or, some corticosteroids to combat the different symptoms we've got going on. Okay. All right, so conclusion for this, allergies and anaphylaxis can be very similar in treatment other than the aggressiveness of the treatment. Okay, so how fast are we going to do it? Which step are we going to start at? That's all going to depend on how these people present. Allergies are abnormal reaction of the immune system that occurs as a result from an otherwise harmless or benign system. The sudden severe hypersensitivity to a substance often results in a reduced airway, dizziness, nausea, and syncope. If anaphylaxis is left untreated, it can quickly become anaphylactic shock, which results in death. And like I said, 0.3 milligrams saves everyone. Okay, that's a good thing to remember there. All right, that's it for allergy and anaphylaxis. We've got one more that we're going to do, and that's going to be seizure management. All right, so we will just jump right into that right now. All right, so some objectives we're going to go over for this one. We're going to list the incidence, the morbidity, and the mortality of seizures across all ages. Okay, all the way from pediatric babies to your geriatric patients. Describe the pathophysiology of seizures, and we're going to identify the various classification of seizures. List the appropriate steps in treating the seizure patient. Okay. Oh. All right. So, what is a seizure? It's going to be a isolated episode of neurologic dysfunction resulting from abnormal activity causing a sudden change in behavior, sensory perception, or motor activity. All right. This can manifest with as many different presentations as there are brain regions. So there's a lot of different possibilities here, okay? They can have many causes. Some are provoked by acute medical conditions such as trauma, fever, infection, hypoglycemia, etc. 2 or more unprovoked seizures that are not due to normal medical conditions are considered epilepsy. Think about the case, or I'm sorry, we didn't go over a case study in this one, but how does this relate to what we see all the time with all of our patients that we see with epilepsy, right? Like we can see these patients that you've got those pediatrics with febrile seizures, and you're like, has this ever happened before? Mom's like, no, never. And you never run on them again. That's not this case, right? Whereas you've got your 13-year-old that, mom found him unresponsive, was post-ictal within 2 minutes, ended up being okay, went to the hospital, drew labs, did everything. Everything was normal. CT was normal. 3 days later, same thing happened again. This time it happened for 2 minutes. The seizures did, or the convulsions did. All right. Still went to the hospital, this time by ambulance. By the time the ambulance got there, they were still post-ictal, but they were responsive, coming around. Still, MRI, CT, labs, everything normal. But this time the ER doctor is going to probably make sure that we've got a pediatric neurology appointment, right? Because at this point, we've got 2 incidences of unexplained seizure activity. Why is this happening? Right. So we've got to get to the bottom line of this and figure out why we are having these episodes. Right. So incidents. Epilepsy is going to be one of the most common neurological conditions, which approximately 5% of the population experiencing a seizure. 3 million people affected, with approximately 200,000 new cases every year. Right. The immature brain in the infant has less inhibitory input and therefore has a lower threshold for seizures. Okay, so that's why we can manage our fevers a lot better than these kiddos can, especially these babies, right? The febrile seizure for a pediatric patient is not unheard of. I mean, I've lost count of how many pediatric seizures I've ran, and most of them are going to be febrile, something to do with the temperature. 25% of children who experience unprovoked seizures will not have any further seizures in childhood or adulthood. So, morbidity and mortality. Several epidemiological studies have attempted to measure the impact of epilepsy on a person's life. The following results are from a large population-based longitudinal study of adults with a history of childhood epilepsy. All right, so they had some type of epilepsy as a child, and these are the people that we've gone out and we've gotten answers from, right? At the age of 33, 55% of the participants reported having no seizures, and they were no longer being monitored for epilepsy. So life went on, right? 48% of those were reported to still have some type of epilepsy. 42% were registered for services for the disabled. So it was profound and severe enough that they are on some sort of disability. 60% of those had a driver's license, and 65% felt their epilepsy had a significant impact on employment. All right, so that's kind of profound there. That's shocking. 65%. That's a pretty tall number. Pathophysiology of genetic seizures. There's 2 main causes of this. Going to be genetically predetermined or acquired. All right, so your genetic seizures are going to be generated by ion channel malfunctions that are responsible for initiating intense activity in the neurons, resulting in the rapid spreading of this abnormal intensive electrical activity. Okay, when the excitatory rhythm forces of the thalamus exceed the inhibitory actions of the cortex. So you've got a special delicate balance of thalamus and cortex, right? And if the excitatory rhythm forces, that electrical impulse from the thalamus, gets to be too much for the cortex to keep up with, too strong, too fast, out of sync, out of whack, whatever the case may be. But if you don't have that relationship between the thalamus and the cortex, that's whenever your generalized seizure is going to occur. Okay, that makes sense? So you've got to have that happy, cohesive relationship between the thalamus and the cortex. And if one of them is too excited or the other one is not excited enough, here we are, right? All right, pathophysiology of an injury seizure. All right, so the cortex of the brain is the greatest risk for infection of trauma, right? Which can alter that relationship, right? That we talked about. So injury of the cortex results in a reduction of the inhibitory force, and subsequently, the delicate balance is disrupted. That all too important relationship is no longer there, right? Even though the percentage of individuals with head trauma who develop or experience subsequent seizures is relatively low, the large number of head injuries that occur every day make the prevalence of post-traumatic epilepsy a significant problem. All right, so we've got a pretty big issue with head trauma, right? There's a lot of head trauma. And then later on down the line, some type of secondary seizure activity in regards to that or because of that. Children younger than 5 years of age have a greater than 9% chance of having post-traumatic seizure following a head trauma. The incidence between individuals between 46 and 65 is only 1.5%. So pretty low, okay? All right, so your generalized seizures. You've got 2 categories of a generalized seizure. Your secondarily generalized partial, it's going to start as a simple partial motor seizure, a simple partial sensatory seizure, or a complex partial seizure. The cortex surrounding these seizures focus is unable to contain the abnormal electrical activity. So you don't have that relationship, and that cortex in that area of the brain, that part of the cortex, is not able to keep up. And that seizure activity grows both electrically and clinically. So as it's not able to keep up and the thalamus is still firing off, it's going to, gradually get worse and worse and worse and worse because that electrical activity's got nowhere to go and you've just got a storm brewing, right? And you've got primarily generalized seizures. These are genetic and represent 30% of all epilepsy types. All right. The electrical pattern of the cortically recorded EEG is derived from electrical impulses initiated and sent from the thalamus to the cortex. So it's still, the thalamus is firing off and the cortex is not able to comprehend it. Okay. So your partial or your focal seizures, each region of the gray matter, which is, the brain is surrounded by gray matter, right? It's got gray matter all in it. Is responsible for highly specific function, and each section of the gray matter is responsible for a certain thing. Okay, the manifestation of a partial seizure is related to the focal area of the brain involved, or area of the brain that's involved, right? So, if, for instance, the portion of the brain that is being affected is arm use, where you pick up your arms or retract your arms or extend your arms or put your arm above your head or whatever. Or your legs won't stop shaking or, whatever the case may be. Depending on where in the brain it is going to be how it produces or how it presents. The functional responsibility of the region involved in the seizure will be interrupted during the seizure. Each area of the seizure of the motor cortex represents an area of the body. So when a seizure takes place in that area, it causes that muscle group to react. Okay, makes sense there. It's pretty self-explanatory as far as that goes. Evaluation of a seizure. All right, so supportive care is going to be the first step that we do. It's going to be the first thing that we do when we approach the patient. Make sure that there's nothing around them that they can hit, when they're convulsing, nothing like that. The greatest concern is the physical harm to the body that occurs as a result of the fall following the loss of consciousness. Positional asphyxia may occur as a result of the uncontrolled movement caused by the seizures. And then hypoglycemia may cause a seizure. So a rapid determination of blood glucose is definitely necessary. Okay. We want to get that blood glucose level as soon as we can, because if that's the reason why they're seizing, we can fix that pretty quick. All right. So treatment. If the patient is still actively seizing, then they should be rolled to their side to prevent aspiration of saliva. Odds are they're going to be drooling a lot. They're going to have a lot of saliva production. So we want to roll them on a recovery position. That way that can all just drain out of their mouth, right? And if they vomit, also can just drain out. They don't aspirate on it. No object should be placed in the patient's mouth. This isn't 1966, okay? We are not worried about them swallowing their tongue, okay? There's no evidence that the tongue will obstruct the breathing either, okay? If we think that that is something, then we have the correct tools for that, right? To prevent injuries, cushion the head and loosen any tight garments around the neck. That way they don't suffocate themselves or choke themselves out. Document the length of the seizure, type of movements, head or eye turning, and the time required to return to alertness and full consciousness. That last bullet is very important. When you transport a seizure patient to the ER, I guarantee you the doctor you give report to is going to come up to you and ask you those questions. Okay? So if you can give him an answer, he's going to be a lot happier, or she's going to be a lot happier. Okay. They are going to ask you these questions. So if you can have the answers to them, better off you're going to be. All right. Treatment of a seizure on a basic level. So ask about the events leading up to the seizure. What was happening? What were we doing? What was going on before they started seizing? What precipitated it? Do they have a history of epilepsy? Are they taking their medicines? Did they miss a dose? Did they just get a medication changed? Did they just change their dose? What's happening? Active infection, any trauma, hypoglycemia, substance abuse, third trimester pregnancy, etc. Which that third trimester pregnancy, we know what that is, right? If the patient experienced head trauma immediately before the seizure occurred, have a high index of suspicion for a potential hemorrhaging in the brain. All right, so you could have a possible bleed there. If the patient is not seizing, ask anyone that witnessed the movements or the loss of consciousness. Oxygen, temperature assessment, and BGL determination and spinal precautions, when appropriate, are a priority. Okay. More treatment. So do not attempt to restrain the patient. Are you restraining them? Can make them hurt themselves more. Okay. We kind of just let them do their thing, but just make sure they don't hit anything or don't hit their heads on anything. Just clear all big obstructions from them. and kind of let them do their thing. If the patient has been prescribed diazepam rectal gel, assist the patient or the caregiver in the administration in accordance with the physician's instruction. I better love you. That's all I'm going to say. If the patient has an implanted vagus nerve stimulator or VNS, suggest the family members use the magnet to activate the VNS. We really don't like to play with those. We try to get the family members to do it if they're there. Reattempt up to 3 times total. Assist if it does not interfere with other care. So, home meds for seizure patients. So these are usually prescribed for seizures. They're called AEDs or anti-epileptic drugs. Phenobarbital is one of the first AEDs widely used by physicians to prevent seizures. Limited use today because of the sedative effect that we've got with it. Primidone is metabolized into phenobarbital and other active metabolites. Also, still not really used too much because of the sedative side effects. Dilantin. It's most widely used for secondarily and partial seizures. Tegretol is used caution in patients with generalized seizures. Depakote is another one that's pretty common, used for treating primarily generalized epilepsies and has a relatively short half-life. Lamictal is used to treat partial seizures as an add-on, since approval has been found to be effective against generalized as well. Gabapentin, pretty common, used for treatment of partial seizures and secondarily generalized. And Keppra, used for treatment of partial seizures and has gained approval for primary generalized as well. Your VNS magnets, kind of what they look like here. One, you're going to respond. Always carry the magnet with you so you are ready to respond. So if you've got one of these and they probably have the magnet like an Apple Watch or, like a watch like on the wrist, they're going to move the magnet over the generator for less than 2 seconds. Okay. And I think they attempt this like 3 times in 1 minute. And other than that, that's pretty much it. I have not been able to use these once in the field. I've seen it used in the hospital once, but it wasn't my patient. So, but it was pretty quick and it was pretty neat how it worked. All right. Conclusion for this. So, emergency medical personnel may play a critical or does play a critical role in the evaluation and the treatment of patients experiencing seizures. Supportive care, rapid assessment of vital signs is crucial in the first minutes of being on scene, okay? The recognition of injury, if there is one, either causing the seizure or as a result of the seizure, is the second step. All right, obtaining a medical history, figuring out if they're on any meds, if they've got a history of the epilepsy, are they compliant? I had a guy that I run on in my district all the time that is epileptic. He's been epileptic for a while. 99% of the time he's good, but the only time we ever run on him is Monday mornings, and the only time we run on him on Monday mornings is when he goes out with the boys the weekend before. Okay, so if he goes out with the boys the weekend before and he goes drinking and he goes out and he drinks alcohol, then Monday he's going to have a seizure. All right, he's up to date on his meds. He's compliant. Everything's good. But if he drinks alcohol, it triggers it. And Monday morning, he's seizing. And we're going to go pick him up, take him to the hospital. He'll be there for a day or two. He'll get out, and then we'll do it all again in a couple months. Okay, and it's inevitable. It happens time and time again. But that's his trigger, and he makes his choice, I guess, right? If the patient is not stabilized, medication treatment may be required, and we got into that, that rectal gel. But you guys, as EMT providers, as BLS providers, kind of got your hands tied as far as how we can treat these, right? Other than supportive care, the primary priority at this point is to bring the patient to the most appropriate emergency room as soon as that can be accomplished. All right. That's pretty much it for everything, guys. That is all 3 slideshows for Medical Module 3. I hope you guys enjoyed it. I hope it was nice and informative. There's going to be a little small test that you're going to take that covers all of what we went over today. Shouldn't be too hard. We got into all these topics really good, really deep, really thorough. So knock that test out real quick, get your hours, get those CEs put in. That way, you don't have to worry about it at the last minute and all that good stuff. Above all else, guys, thank you for your time. Stay safe out there, and we'll see you next time. All right. Have a good one.